Obesity is increasingly becoming a national health concern. As many as 66% of U.S. adults are classified as obese or overweight. Obesity is defined as body weight greater than 20% of ideal, whereas overweight refers to increased body weight correlated to height. Body mass index, or BMI, is the most widely accepted and accurate way to evaluate obesity. It's calculated as weight in pounds divided by the patient's height in inches squared, then multiplied by a conversion factor of 703. A BMI of 25 to 29.9 is considered overweight. Over 30 is obese, and 40 or greater is morbidly obese. Comorbid conditions are closely associated with obesity, including left ventricular hypertrophy, myocardial ischemia, and CHF. It's mandatory to take an in-depth history before providing anesthesia to an obese patient. Aspiration is of greater risk in this patient population, particularly those with a history of gastroesophageal reflux disease. Patients with obstructive sleep apnea syndrome, or OSAS, carry their own subset of comorbidities. Those include hypertension, hypoxemia, hypercarbia, polycythemia, and cor pulmonale. After the patient evaluation is complete, decide whether to proceed with office anesthesia or to schedule the patient for surgery in a hospital setting. There are special intraoperative considerations for the obese patient. A standard blood pressure cuff will produce an elevated reading with increased upper extremity diameter. The width of the cuff should be greater than 1/3 the circumference of the arm. IV access may be difficult to establish because of subcutaneous adipose tissue. A tenuous IV should not be satisfactory prior to surgery. Monitor the IV site closely to rule out local infiltration. In an obese patient in the prone position, chest wall excursions are more difficult, and there is upward pressure on the chest from the diaphragm. Because of that, place the patient in the upright or semi-Fowler's position. The pharmacology of anesthetic drugs may be altered in an obese patient. Adipose tissue has a relatively lower blood flow, and an induction dose calculated on milligrams per kilogram may exceed desired plasma concentrations. Lipid-soluble drugs may re-enter the circulation over a prolonged period of time and can increase recovery time. In general, administer small doses of IV drugs slowly until the desired effect is achieved. Obesity summary. Preoperative. Take an in-depth history with particular attention to cardiovascular conditions, gastroesophageal reflux disease, sleep apnea, and other respiratory conditions. Consider consultation with the patient's primary care physician. Consider using a hospital surgical setting. Intraoperative. Use BP cuff 1/3 greater than arm circumference. Consider IV BP monitoring. Monitor IV site closely. Consider catheter over needle system. Place patient in upright or semi-Fowler's position. Have appropriately sized airway adjuncts. Use the lightest form of sedation and administer slowly to desired effect. Postoperative. Give careful consideration to appropriate postoperative analgesia. Extended recovery time may be warranted.